Okay, welcome everybody to our presentation on post-traumatic stress disorder, multicultural outcomes and practices, brought to you by Angela Blanco, Stacy Kellar, and Tiffany Ward. Post-traumatic stress disorder is a trauma response to experiencing or witnessing a traumatic event. The key features are intrusive thoughts, avoidance behaviors, changes in thinking and mood, arousal and reactivity, or hypoarousal and reactivity. The specific responses to a traumatic event are very much influenced by culture, but the key is that whatever cultural background someone comes from, PTSD creates a significant impairment to their everyday life. PTSD presents differently in different groups, and cultural and ethnicity have a great effect on its expression and its risk. We're going to talk about four groups today. Talk about folks living in poverty, adolescents, Asian Americans, and the military. The epidemiology of PTSD varies considerably. Overall, 6% of the US population will have PTSD at some point in their life. For veterans in general, it's a little bit higher at 7%, but for female service members and veterans, it's at 13%. Adolescents have currently 8% lifetime PTSD, but that's 8% for girls and 2.3% for boys. Asian Americans, according to the research we have, is 4%, but it may be higher. And among refugees, it's much, much higher. And among folks who are impoverished, we know that poverty greatly increases the risk of PTSD, but there are no national numbers about prevalence. The history of PTSD and the American Psychiatric Association is interesting. PTSD has been recognized since ancient times. It was described in the Iliad and the Odyssey, 7 centuries before the Common Era. From the diagram, it's had many names over the years, most of them associated with military. Talk about shell shock and exhaustion delirium, combat delirium. But it was first recognized by the American Psychiatric Society in 1980. And the key thing is that it was a revolutionary concept that the cause of a disorder could be outside the individual. For virtually every other disorder in the DSM-5, the cause of the disorder is intrinsic. It's something within the person that may interact with the environment. For PTSD and stress-related disorders, the cause is viewed as being outside the individual. So in the DSM-5, there's a diagnostic pathway, and this diagram shows the pathway for diagnosing PTSD. The first question is, was there a traumatic event, a threat to life or limb, a sexual assault, an event that would trigger the fight, flight, or freeze response? Did the person directly experience or witness the trauma? You can get PTSD from witnessing traumatic events as well as from experiencing it firsthand. If those two things happened, if there was a traumatic event that the person directly experienced or witnessed, do they meet the symptom criteria? Because not every trauma exposure results in PTSD. So, do they have new or worse intrusive thoughts? Do they have new or worse avoidance of things or places or people? Do they have 2 or more changes in cognition and mood? And do they have 2 or more changes in arousal and reactivity? If all of these things are true and the duration's more than a month, and there's distress and impairment, then PTSD can be diagnosed. And I won't spend a lot of time on the diagnostic criteria here, but you can review them in the slides later to know very specifically what do each of the criterion mean. So the causes of PTSD are external and they're culturally framed. So it's witnessing or experiencing traumatic events. It can also happen from being the perpetrator of a traumatic event. So we can think about combat situations, we can think about refugee situations, think about environmental disasters in which someone may take action to save their own life, but that action causes grievous harm to someone else. Not every traumatic event results in PTSD, but cumulative trauma and compound trauma increases the risk. And potential causes range from, and this is not a full list, domestic violence, war, sexual abuse, physical abuse, emotional abuse, witnessing or experiencing disasters or accidents, bullying, experiencing racism, experiencing racial or ethnic hate, or any kind of, stereotypical based hate, from medical procedures, from the death of a loved one, from adoption, from separation. Um, any perceived threat can be a potential cause. So what are the desired outcomes and the goals of treatment? The most desired outcome is a return to the pre-trauma level of functioning, but that's not always possible. What most people seek is to regain a sense of control over their life, to improve how they interact with other people, to be able to better handle stressful events in the future, and to change their disturbing thought patterns. And all of these outcomes really rest on the person learning coping techniques to reduce PTSD and carry out normal daily activities.
And we're going to cover with you today 3 current approaches and take a look at the diversity and multiculturalism in each approach. First, we will discuss the cognitive behavioral therapy approach, or CBT. What is CBT? This is a type of therapy that focuses on the relationship among thoughts, feelings, and behaviors. And it also notes how a change in just one of those domains can actually improve functioning in the other domains. For example, you could alter a person's unhelpful thinking. Having that would lead to a healthier behaviors and improved emotion regulation. This particular treatment, CBT, is strongly recommended for the treatment of post-traumatic stress disorder. Some diversity and multiculturalism considerations. Social and cultural dimensions are honored when clinicians develop a therapeutic stance, which involves the appreciation and understanding of the complexities of a client's lived experiences. Cultural dimensions with this modification to CBT are done to validate experiences of racism while also disputing the veracity of negative self-focused thoughts. Some institutional dimensions are addressed through changes to reflect relevancy and accessibility to ethnic minority groups by introducing family involvement, use of appropriate language terms, and understanding psychopathology from a cultural viewpoint. Additionally, there's an emphasis on institutional and physical dimensions, which includes medical institutions, the Department of Veterans Affairs, and other federally funded institutions that provide direct medical, physical, and social support. Social dimensions requires continued advocacy for clinical mental health services, social services, community services, both within the public and private settings, and funding for continued research and advocacy is needed. Second, we have the humanistic therapy approach. What is this? This is a form of talk therapy that focuses on a person's individual nature, rather than assuming that a group of people with similar characteristics have the same concerns. Its aim is to really find the strengths and build potential to move forward, getting past barriers. A humanistic approach to trauma focuses on the transformative therapeutic agents that help individuals move from victim to survivor and thriver in the face of trauma. This has been used to treat depression and substance abuse misuse caused by PTSD. And some cultural and multiculturalism and diversity considerations are identified. There are challenges with this model from a multicultural perspective, and that is with institutional dimensions where all clients are treated the same, which could result in the therapist misinterpreting or ignoring critical information in the assessment and treatment of the individual of another cultural origin. Cultural dimensions must be addressed to include the use of terms that may or may not have the same meaning between the client and the therapist. An example of this would be with the term self-esteem. This is more appropriate for a client from an individualistic society and likely does not have the same meaning in a collectivist society such as Japan. Social dimensions require the therapist to adjust their values, assumptions, and goals to the lives of the clients, thus relying on the theory's origins in white Western culture. And lastly, this form of therapy has not been shown to be as effective as the therapies that use exposure to stimuli and memories associated with the trauma. And last, we will talk about cognitive processing therapy. And as you can see from the diagram, it is a matter of taking a look of what became aware of their feelings, learning about their symptoms, and learn skills to challenge these thoughts. CPT is a specific type of cognitive behavioral therapy that helps patients learn how to modify and challenge those unhelpful thoughts related to the trauma. The patient slowly becomes more aware of the relationship between thoughts and emotions and begins to identify automatic thoughts that may be maintaining PTSD symptoms. And some diversity and multiculturalism considerations with institutional dimensions include the endorsement by the U.S. Departments of Veterans Affairs and Defense, as well as the International Society of Traumatic Stress Studies, as a best practice for treatment of PTSD. Social dimensions are also addressed in part with the CPT treatment manual being translated into 6 languages.
Proactive steps to affect the desired outcome. First, the therapist must know the symptoms of PTSD. They need to help identify triggers and make a plan for the triggering events. Help create routine and structure. Through routine and structure, that allows for consistency with the client. And each mental health professional should develop their own personal self-care plan. Alternatives to affect the desired outcomes. There are various other therapies associated with lessening the symptoms of PTSD. These include, but are not limited to, creative therapy, narrative exposure therapy, prolonged exposure therapy, music therapy, and psychedelic assisted therapy. Breathing work in conjunction with mindfulness, resilience-based interventions, which focus on social support through friends, family, and support groups. This does help with coping mechanisms. And then there's also the use of medication. Expected resistance with the PTSD population, the inability to trust the counselor. They have a hard time getting close and communicating. This does affect the problem-solving ability. Avoidance is also a huge coping mechanism, whether it's avoiding therapy altogether or avoiding the subject of the traumatic event in the therapy session.
PTSD presents differently in different populations. In military populations, it's slightly higher than in the general population, but much higher in women. Some military-specific causes of PTSD include exposure to war zones and to the aftermath of war zones, combat-related and training accidents and injuries, and military sexual trauma, which very disproportionately affects women. Some treatment considerations specific for folks in the military are to be aware that there can be an increase in risk of substance use disorder and other mental health disorders, that traumatic brain injury may complicate care, and traumatic brain injury is much more prevalent, particularly in combat veterans, than in the general population. Veterans and military active personnel may be really hesitant to seek or continue treatment due to the stigma of having a mental health disorder that exists in the military and the potential effect on their career of seeking treatment. Additionally, care may be inadequate, particularly in non-military settings. Counselors who don't have experience with military populations may not understand the context in which PTSD occurs for military personnel. And effective treatment modalities have been identified, and two of these are prolonged exposure therapy and EMDR. Another population deserving of special consideration are Asian Americans. While PTSD might be lower in the Asian American population, we're not sure. The research isn't that great, but we do know that it's much higher in refugee populations. In some Southeastern refugee populations, rates of PTSD as high as 70% have been found. It's likely to be associated with repeated exposure to traumatic and catastrophic environmental stressors, such as war, fleeing war, living in refugee camps, experiencing firsthand violence, witnessing terrible things happening to others. And finally, the journey of a refugee to a place of asylum in itself can be traumatic. There's a number of treatment considerations that may be of more concern in Asian American populations, although it's important to remember that people are individuals and not every member of the group will have all of these. There may be a greater concern about shame in disclosing and seeking treatment for mental health. As a group, culturally, there's a hesitancy to seek out help through the mental health system. There may be a preference for friend and family support to work through mental health issues, or for traditional healers, particularly for older Asian Americans. There may be language barriers, there may be financial barriers, particularly for refugee populations who may not have health insurance or finances to pay for counseling. However, there is some good news. There are culturally adapted treatment options that show promise. And another adaptation that shows promise is pairing mental health professionals with community members and paraprofessionals to ensure the care is more culturally competent.
PTSD in adolescent populations, 5% of adolescents met criteria for PTSD, 8% of girls versus 2.3% of boys. The number here is higher in girls due to the prevalence of sexual assault against females. Signs of PTSD in teens can include poor performance in school, difficulty making and maintaining relationships with peers, reckless, aggressive, and/or self-destructive behavior. Treatment considerations: teens may have trouble talking about what they are feeling and/or the event itself. Sometimes their language is just not capable of expressing what is truly going on inside. They may need to find the right provider, and this is going to be by trying out a few and finding the one that is most comfortable to them. There's also that stigma that's very high in the teenage population that getting help for their mental health is embarrassing.
PTSD in populations living in poverty. Socioeconomic status contributes to the majority of anxiety disorders of those living in poverty. There are higher rates of PTSD symptoms than members of the general population. They may suffer from ongoing exposure to stressors which trigger recurrent symptoms from living in economically disadvantaged neighborhoods. And they may have access to fewer resources that could serve as a protective factors against the development of PTSD symptoms. 8.7% of people with income below the poverty line report severe psychological distress. Some treatment considerations: the lack of insurance coverage and the cost to providers was cited as the reason most people living in poverty do not access mental health services. Low-income clients are concerned with the survival on a day-to-day basis, and they may seek advice and suggestions from their counselor. They're less likely to seek formal mental health services. And in addition, the average counselor doesn't have adequate training or even a good frame of reference when it comes to clients living in poverty. Some counseling implications with regard to family counseling first. Sharing feelings and honestly and openly with respect and compassion is a possibility through family counseling. Relationships may help the survivor's self-esteem. It also provides an atmosphere that allows for all parties to safely express their emotions.
Counseling implications for clinical mental health include the client having difficulty opening up to others. This is that trust that they don't have with other people. Resistance can take the form of canceling appointments, avoiding certain topics, or only engaging in small talk. Treatment-resistant PTSD, which is described as remaining symptomatic for 6 months after support counseling, as well as at least 6 months of SSRIs, does approximately affect 33% of PTSD sufferers. School counseling implications: we want to nurture partnerships with students, families, and staff, assist in creating a trauma-informed learning environment. This includes the awareness of what trauma-based reactions look like. We also want to help develop the student's strengths and interests, get them to focus on something more positive. Advocacy and activism. Advocacy is public support for a specific issue and for the people affected by that issue. Those living in poverty, counselors must be prepared to address systems of oppression, discrimination, marginalized statuses, and the impact these factors have on counseling services and clients' well-being. Advocacy with Asian Americans, speaking out against Asian American hate and educating the public on the lasting harm it causes. Within the military community, we can support legislative goals such as the Wounded Warrior Project by writing our congressional representatives. And among the adolescents, school counselors can provide community resources to students and families, educate staff on the effects of trauma, collaborate with community resources, and promote a trauma-sensitive framework for policies, procedures, and behaviors to the staff. The trauma's impact on learning is at the center of the educational mission. Thank you so much for partaking in our slide presentation of PTSD among marginalized demographics. We have included some references and websites if you should find yourself working with a client suffering from PTSD in any one of the demographics or anyone in general. You can find some help by visiting these websites. Thank you so much.